Welcome back for part 2 of Bigger, Faster, Stronger. In this part, we want to focus on applying the principles of bioethics to the issue of medical and genetic enhancements. Recall from Wasson's piece, Medical and Genetic Enhancements, Ethical Issues That Will Not Go Away, that the medical and genetic enhancements debate brings out a tension in medicine between individual autonomy and the common good. For our purposes, we can translate this tension into one between the principles of respect for persons, as well as beneficence, and justice. I include both respect for persons and beneficence on one side because, as we saw throughout last week especially, beneficence is normally understood, in the medical context, as applying to the individual patient. A physician's duty of beneficence is a duty to do good for her patient, not necessarily for society at large. Recall Hellman and Hellman's claims from week 2, where they argued that it is exactly because a physician is supposed to prioritize her patient's needs before society at large that clinical trials are unethical. So often when we speak of beneficence, we speak of benefiting the very same individual who is requesting the intervention. Thus, respect for persons and beneficence are often linked. And so when applying the principles to the issue, there are at least two major questions we want to ask ourselves. First, when can considerations for society at large outweigh individual freedom? As we will see, many of the major criticisms of enhancements revolve around concerns of inequality and social injustice. But then the fundamental question is, when do these inequalities become so great, or the injustice so extreme, that we are justified in restricting individual freedom? We often protect individual freedom of choice and action, even in the face of negative societal consequences. Much of the recent debate over guns is a great example, as well as the protection of hate speech. So is enhancement more like those cases, or is it more like the case of speech we do restrict, such as yelling fire in a crowded room? This issue brings us all the way back to the story of Amalas. Although you may not feel as strong of a pull for the individual who wants to be bigger, faster, stronger, but is told she cannot because it would make society worse off, the basic tension is the same. How far are we willing to restrict individual freedom and autonomy to prevent harm or to benefit society as a whole? The other major question is somewhat related. I said before that the duty of beneficence in the practice of medicine is generally understood to apply to the physician's patient that is right in front of her. She is supposed to ignore, at least in terms of benefiting, the wider society. But perhaps this is not the way we should be understanding beneficence. Perhaps beneficence in practice should be more like beneficence in research, where we do take into account the sorts of benefits and harms that an action will have on society as a whole. Our answer to this question is important, because if we maintain the current view that beneficence easily sides with respect for autonomy and will generally appear in favor of enhancements. But if we expand its application, it may start to look a lot more like considerations from justice, and therefore possibly against enhancements. So keep these questions in mind as we explore the enhancement debate through the lens of autonomy, beneficence, and justice. We want to start with evaluating enhancements from the perspective of autonomy. At first glance, there seems a pretty clear comparison to something we already have in medicine: elective procedures, particularly cosmetic surgery. So are medical and genetic enhancements like faceless or other cosmetic or elective procedures? And if so, does that mean they should be relatively unrestricted? So long as someone is willing to pay for the procedure and a physician is willing to do it, then is that all there is to it? Well, one way they seem similar is that both can be viewed as aimed at giving the person a leg up in terms of certain competitive goods. Competitive goods, as Glannon explains, are goods that are essentially comparative and which give a greater advantage the more one has. Beauty, intelligence, sociability are examples. Someone is more or less beautiful than someone else, and beautiful people are treated differently than those that are not considered beautiful. Cosmetic surgery is often aimed at improving someone's attractiveness, aimed at giving them a competitive edge, or maintaining it when they would otherwise lose it. Many enhancement techniques have the same goal: make people more intelligent, stronger, faster, all traits that people tend to think are good and that are in some sense competitive advantages. Research shows, for instance, that people with blue eyes are considered less trustworthy than people with brown eyes. So it may be that having brown eyes is a benefit over having blue eyes. So that is one way in which enhancements look quite like cosmetic surgery. And so if we think that cosmetic surgery is acceptable, in large part due to its elective and autonomous nature, then perhaps enhancements are acceptable as well. But not all procedures are elective procedures. For instance, we do not, absent being someone like Dick Cheney anyway, tend to let someone buy a new organ, especially if they do not need it. There are various reasons for this, including the fact that organs are in short supply, but we may also think that it is unfair that there are many people who need an organ, but only those with money would be able to get it. And so we feel justified in restricting individual freedom to purchase an organ due, at least in part, to the unfairness of such a system. We can also question whether enhancements would truly be autonomous overall. This can be done in two ways, one that applies to all forms of enhancement and one that applies to the enhancement or genetic selection of unborn children. In the first case, recall the clips from Gattaca, where Vincent's parents were considered odd for having him in what had become the unnatural way, without the help of a geneticist. Moreover, consider Vincent himself, who was a member of a new underclass of genetically inferior beings. More generally, think about our own culture, where perhaps due in part to the rise of cosmetic surgery and the like, there is great social pressure to be a certain body type, to look a certain way, and such pressures sometimes result in harm to people due to ridicule or body image issues, or other similar concerns. What all these examples point to is that sometimes something that looks like an autonomous choice may not really be an autonomous choice. If everyone is doing it, then not doing it has additional negative repercussions that now may change your deliberation. Feminist philosophers have been especially keen to point out the non-individual nature of autonomy, that one's social conditions shape one's set of choices and also may alter her deliberations. No one really wants to be an outcast, and so if taking an action has a chance in resulting in that, then that counts against the choice. So on one hand, you can claim that it is nevertheless an autonomous choice. You obviously could make the choice that results in you being an outcast. But you may also claim that such pressures are undue influences that force people to choose against their will, or at least with diminished autonomy. To the extent this sort of concern is right, it may make considerations of autonomy less in favor of allowing enhancement. But one concern we may have with this approach is that it isn't realistic for medicine. If we have to take into account such dynamic social forces in deciding whether someone is autonomous or not, it may make it impossible to ever truly get informed consent. But medicine must go on. We must be able to get informed consent. So even if social pressures do affect autonomy, we must mostly ignore such considerations or risk paralyzing medicine as a whole. A second consideration is one that is popular in the debate over designing babies and selecting children. It is often discussed as a child's right to an open future. Here the concern is that in designing a child, you are violating what some have called their anticipatory autonomy rights, those rights of autonomy we anticipate they will have later in life. This is because in choosing certain traits over others, we are limiting what sorts of options will be open to the child later in life. To the extent this concern is right, again we may think autonomy starts to count against selection of the best embryos and against fixing children before they are born. But there should be a concern here too. First, it isn't clear we have denied them anything, given that most selection, as I mentioned in Part 1, only predisposes a child to a trait. It doesn't guarantee they'll have it. Further, every child is always limited by chance, given genetics, so why is it only bad if we do it intentionally? Additionally, we need to ask about the duty of respect for persons. Whose autonomy should a physician care about? Usually, we think just the patient's, but this consideration is asking the physician to also think about a non-existent being's autonomy, which seems very odd, especially given that the dominant paradigm for understanding reproductive choices is what some call procreative liberty, which gives extensive freedom to prospective parents to choose when and how to have a child. We don't license parents, for instance. We let them just make their own decisions, even if sometimes it turns out worse for the child. So why should we respect the child's anticipatory autonomy rights in this case, but not in others? So respect for autonomy looks, initially, to be in favor of enhancements, but there are some complications. But how about beneficence? Well, initially, it should look quite in favor of enhancements. If beneficence obligates physicians to maximize the possible benefits to a patient, or to improve her well-being as much as possible, then insofar as enhancements could make people better off, the physician looks perhaps even obligated to perform them, or at least if she does so, she's doing nothing wrong. This is Sovolescu's view. Remember, on his view, we all want the best life, the life with the most well-being. And treating and preventing disease helps us achieve that. But so could enhancing us beyond normal human functioning, or selecting children based on non-disease genes. And this seems to fit best the way the Belmont Report explains beneficence, as maximizing the possible benefits. But there is another view, one supported by Glennon. If we see medicine as being restricted to maintaining and restoring health to normal levels for the age and sex of the patient, then the duty of beneficence has a limit. It implies making people better off up until the point of average or normal. Anything further would be outside the goals of medicine. So certainly this view doesn't fit with how the Belmont Report defines beneficence, but that is okay. Our understanding could have evolved since then, especially since the Belmont Report was written in the context of research more so than practice. But what is more interesting is that this view seems to imply that whatever is statistically normal, whatever is average for a given trait, is good. But again, this cannot be true. Just because 51% of the population has a particular trait doesn't mean having that trait is good and having a different trait is bad. If 51% of the population were obese, physicians couldn't be involved in fighting obesity because that would be outside the scope of medicine, on this view. It is a classic issue in philosophy that appeals to what is natural as what is good, or what is normal as what is good, and such appeals are dubious at best. Recall in week 1 that there is discussion of what's called the naturalistic fallacy, or what Penn's also called jumping the fact-value gap. When you say that because it's normal it's good, or because it's natural it's good, that is exactly what is happening. You are committing a naturalistic fallacy, or the naturalistic fallacy is being committed. And so we should be concerned about this sort of approach that a normal level is somehow meaningful from the perspective of well-being or the perspective of beneficence. And just like autonomy, we can also question what exactly the duty of beneficence amounts to in the context of enhancement. As hinted at before, we can ask the question of whose good counts. If the case of enhancements is just like the case of general medical practice, then the emphasis is solely on the patient's good. But maybe we think we should expand beneficence to be more like the beneficence of research, a utilitarian beneficence, where everyone counts for one and no one for more than one. By that, we mean that the duty of beneficence is a general duty to promote the good of all, and the patient doesn't matter any more or less than any other person. A second concern we may have applies specifically to pre-implantation selection. Normally when we speak of beneficence, we talk about making people better than they were to start with. But Savulescu, in promoting procreative beneficence, is using beneficence in a different way. He is talking about making people that are better than other people we could have made. This is a deep problem in ethics. It may be hard to fully understand at first, but the basic idea is that in selecting one embryo from among a few options, we are selecting what being to bring into existence. So in basing our decision on whichever has the best chance at the best life, we are choosing to bring into existence the better being. But we are not taking a being and making it better than it otherwise would be, as we may do if we repair a genetic defect of a child in utero. The reason this matters is that these are two different uses of beneficence. In one case, the use is applying to beings who could be made better or worse by our actions. In the other case, we are talking about preventing beings with less of a chance of a good life from coming into existence by choosing one that supposedly has the best chance at the best life. Beneficence, as used in medicine, wasn't drawn up with this possibility in mind, and so the use of it now is novel and should require reflection on our part before accepting it. Embryos are not benefited or harmed by being selected for or against. Embryos just aren't the sorts of things that can be benefited or harmed. So for many people, that means that a duty of beneficence simply cannot apply to them, and therefore Savulescu's proposal makes no sense. On the contrary, it doesn't seem odd to talk as Savulescu does about bringing a being into existence with the best chance at the best life. That seems like a meaningful thing to do. So maybe it should be a part of a wider understanding of beneficence, even if it's not currently a part of our understanding of beneficence. Appeals to justice, equality, or fairness are the most common way people go about objecting to enhancement. We saw it illustrated in Gattaca, Glannon calls it the main moral concern for genetic enhancement, and Savulescu finds it important enough to spend time thoroughly responding to it. So what exactly is the concern from justice for genetic enhancement? It is not about distribution of risks so much as distribution of benefits. As Gattaca illustrates and Glannon claims, the worry is that the haves will have the enhancements and the have-nots will be left in the dust, to work as janitors at Gattaca rather than as astronauts. Such unfair distribution will result in unfairness of opportunity, as it did in Gattaca, where the genetic losers are simply excluded from many positions in society. Moreover, there is already great social inequality due to various factors such as sex, gender, race, and socioeconomic status, and enhancements will just add an additional method of discrimination and inequality. Moreover, enhancements will just exacerbate the inequality we already have. If those in lower socioeconomic classes are already getting screwed, they'll be getting screwed even more once the rich can lift cars with one hand. For Glannon, this concern is even deeper, because it threatens the very basis of medicine in the first place. As he sees it, the reason we restrict medicine to maintaining and restoring normal function is because we want a baseline that helps ensure fair equality of opportunity for all people. And giving some people an even greater advantage certainly diminishes fair equality of opportunity. One initial response to this worry is to think that we could just make enhancements, at least those judged safe and effective, free or heavily subsidized. Indeed, in an article we didn't read, Savulescu actually argues that if we could make a safe and effective cognitive enhancement, then we ought to put it into the water supply, like we have done with fluoride. But such a proposal faces a few difficulties. The first relates to the therapy enhancement distinction we discussed before. If we label these things enhancements, just as a matter of how things are done now, it diminishes the chance we could subsidize them or make them free. Secondly, and more deeply, the thought of free or subsidized enhancements, especially if funded by the government, brings to mind fears of eugenics of old, where the state would determine good genes and bad genes, good traits and bad traits, and actively work to eliminate bad traits and encourage good traits. Historically, the U.S. did this through forced sterilization of so-called undesirables, but we now flinch at such a proposal. While there is no reason that government-subsidized enhancements would have to lead to such government intervention in our lives, for instance, they could just make them available for free or cheap if people want them, it nonetheless makes people often think of much worse eugenic policies. A more speculative concern regarding the fairness of enhancements is that when major enhancements are available, there will be some, like the woman interviewed by Michio Kaku in the BBC video, who embrace their transhuman or posthuman future, a future where there are beings that have moved beyond Homo sapien as we understand it. And that since these transhumans will be much more capable than regular humans, the result will be something like the technologically superior Europeans marching onto the African or North American continent and laying waste to people they considered inferior to them. A less speculative version of this objection would be the one discussed by Savulescu, that in using genetic engineering to prevent certain disorders, we are implicitly telling people with those disorders that their lives are not worth living. There are ways to problematize these justice concerns as well. In the first case, we can ask whether or not such speculative concerns over inequality, especially given that we already have so much inequality, would actually justify restricting individual freedom. The concerns over inequality are speculative. They may come about if we have enhancements, they may not. And even if inequality does come about, it may not really matter much in itself. And also, even if it comes about, given all the inequality we already have, it may not really make much of a difference above those other inequalities. Given all of that, why would we intentionally restrict freedom, knowing it will guarantee a restriction on freedom, just on the chance that there may be inequality in the future? Similarly, we can give more to the person arguing against enhancements and admit that there would be inequality. But so what? Paying people different amounts creates inequality too, but those who argue for a flat wage for everyone are generally laughed at. Inequalities will exist no matter what. Some people will be more naturally talented or have more natural positive traits that give them a leg up over others. So why should we limit people's freedom over this sort of inequality? A second concern is one raised specifically by Savulescu. Granting that injustice may come about due to enhancements, either the enhancements simply add to current injustices or they make new ones, why would we think the best option to fight such injustices is to ban enhancements and restrict individual freedom? There are certainly other options, and perhaps they are better. As Savulescu puts it, quote, "In virtually all cases of social inequality, there are other avenues to correct inequality than encouraging or forcing people to have children with disabilities or lives of restricted genetic opportunity." Such alternatives include education, fighting for institutional reform, promoting dialogue between people, etc. To the extent that these methods are available and could work, it greatly reduces the force of the justice objection being a reason to actually restrict individual autonomy. It's something we need to be concerned with, but it's not something that makes enhancements themselves wrong. So where does all this leave us? I think we should draw a few conclusions. First, the principles of autonomy and beneficence can go either way on the enhancement debate, depending on your understanding of the principles and how seriously you take certain concerns. Second, justice is pretty clearly against enhancements, but the real question is if the concern is sufficient to outweigh individual freedom or well-being, or if we have alternative ways to combat the issue. And finally, and more generally, the enhancement debate is great in medicine because it shows the importance of clearly defining and understanding what a principle implies. On one understanding of a principle, you may get one judgment about enhancements or anything else, but on another understanding, you will get a different judgment about enhancements or something else. That is why it is important not just to accept the definition of a principle and move on, but to examine the definition and argue for whatever your preferred interpretation of the principle is.